I'm getting yelled at. I've been excited about this for a while. I thought that it would be good to see if we could gather some of the pediatrics people throughout the area, whether they were physicians or advanced practice people, and that we could start having sort of these meetings where we would think of things to talk about in various times and various things. I started at the University of Chicago was in 1996. It seems just a few years ago, but it's been a long time. The university has gotten bigger, and I think the pediatrics has also gotten a lot bigger over that time. And it's been wonderful with Mr. Hackett and the rest of the group that we're here, and we're going to be able to start having these meetings. And I think it's going to be a great addition to our ability to educate as well as advocate and work on the science that we have been. I thought that this first move towards that was going to be a sort of interaction between as many people as possible, so that we can work through a process trying to decide what each of you might or might not want to do in a particular scenario. And I think that between Judy and maybe Julie also, and perhaps me also, would be able to read maybe the first of these few scenarios, and then I would be delighted if the people who like to talk, which is me and a lot of other people, could press the button and read the few sentences, and then begin to decide what's going on. I guess since I wrote the first sentence, maybe I'll read the first sentence. And the way this is working is that there's a couple of sentences at the top, and then something happens to a mother's child, and we'll get to the bottom of it, and then it would be great if we could get some ideas about how you would want to treat that particular patient. So Judy, not the Judy that's in the window there, is a delightful 7-year-old child. She's taking a walk to the rather large park near her house with a rather large ball that she plays with. Her mother is walking with her. When Judy and her mother reach the park, Judy quickly runs over to her friends to play while her mother settles down to read a book. Several minutes later, Judy's mother is startled by hearing a bump and a scream, and runs to see that Judy is intermittently crying, screaming, and whimpering. Another mother calls 911 while Judy's mother tries to calm her daughter down. You're there, you're walking through the park with a friend, and you see a group that's right near where Judy is on the ground, and you come to help. Judy's quieting down, and it seems she is now getting much more awake. So I would ask any of you, I hope that you're enthusiastic to kind of tell me what you are seeing and what you feel you would want to do with this child.
We'll give everybody a minute to drop your answer in the chat. So after we've got a few answers in the chat, then we'll ask for a volunteer to discuss their answer live. So go ahead, think about this scenario, and then drop an answer for us. And even if it's a guess, that's okay. We don't expect everyone to have answers. So we've got one answer right now, which says seizure.
I think there should be more possibilities though, huh?
And then the next one says, any bleeding from ear, mouth, or nose, any obvious mark of external injury. And then the next answer says, get the history from those who saw what happened.
Yes. Okay. I think we have enough things to talk about yet.
Those are the three answers.
Okay, so I wish I had like a little thing that tells me what's in the shop down there. Can you read? You're able to read the answers again, or the?
I'll read those one more time. So the first answer says seizure. Is this a seizure? The second answer says, is there any bleeding from the ear, mouth, or nose? Any obvious mark of external injury? And then the third answer says, get the history from those who saw what happened.
So I guess now we can have a little bit of a discussion, if that's okay. Seizures, relatively common, I guess, especially around a neurosurgeon. Though in this situation, it probably is hard to decide exactly what's happening unless we have more things to look at or look for. How would we get more into that? That's the next question. If someone wants to chime in.
Refresh us, Dr. Frim, since we can't see what the scenario was. At least I can't. If it's up, I missed it. Remind us what the details were. The mother can't really see what has happened, and the child is crying, right? And then seems to settle herself.
Yeah. So she's crying. She's crying. She's whimpering. One of the mothers is dialing 911. I guess she wants to find someone to come help, and the mother's calming the daughter.
Okay.
That's sort of the general scenario. It could be many things. To be honest, I wrote it in a way that many things might be reasonable here, and then we can talk about what we would do depending upon which way we're thinking to go with the child.
So I think it's really interesting that one of the answers was get more information from the people who may have witnessed it, because at least in my experience, when the kids show up at our door at the emergency room, which is really a way escalation of this particular scenario, find out what happened. It helps everyone kind of gauge if this kid had a seizure, was this kid just, playing and then all of a sudden fell? Would one of the other kids say they fell in a weird position? I happen to watch over the weekend, I watched a girl have a seizure in the middle of the volleyball court, and the way she fell to the floor, there were several parents, knowing that we were going to give this talk, I was listening to how people responded. And there were several parents that commented how unusually she fell. She didn't fall, in a way that somebody had knocked her over, or that she had tripped. So I think the answer of get more information gives a lot of information to the next level of decision making or deciding what the risk is. So I like that answer myself.
Yeah, clearly more information is always going to be good here. And I think what's important is that there are people around. So it should be easy to find out what was going. Was she screaming? What maybe the ball hit her in the head? That might cause a similar problem. So these are all things that that we should know about if we're wanting to come and lend a hand. Well, what other things could this be? She's crying, she's screaming, and then she quiets down. Do we want to do an exam? Right, we're all doctors, right? It says there, you and a friend are walking by, so.
Well, and knowing even with what I experienced this past weekend, parents are going to look for someone, and even if pediatrics is not your specialty or neurosurgery is not your specialty, they figure out you're a doctor or a nurse, they're going to say, oh, you have to come help. They want us to respond. One of the other answers in the chat, Dr. Frim, was there any sign of injury, a direct contact, like bleeding from anywhere or broken skin of some kind? And I think that's a great follow-up part of the assessment, that any provider can do on the scene.
Yeah.
Mm-hmm.
So we're starting to get into what I think is going to be giving the patient a quick look and then talking to who's ever around to find out what was happening. And then with that information, start to look at the child and see if she's getting sleepier, or if now she's starting to get more and more awake. And those kinds of things. And that's probably going to be important in this too. Okay. What does quieting down do? Does anyone have any ideas about that?
And feel free to unmute yourself and answer the questions and engage. So this is an informal meeting, so feel free to speak as you feel.
Yeah, I think the broken the brokenness of our communication is going to allow a lot of people to talk rather than just write.
I guess quieting down may mean that she's not having as much pain.
Yeah, I guess it has to go one way or the other, right? If it's quieting down and becoming less and less active, so that's telling something that might be more worrisome than just than anything. Or the quieting down is that now the child is able to move and talk again and start to be sort of more normal. I think that's we have to investigate that and find out which direction is it. you could, by that time, you might be able to actually ask the child, did you get hit by the ball in the head? And that might help what's going on.
One of the comments in the chat, Dr. Frim, was, was there a loss of consciousness? I think that's a popular question for all of us, on the sidelines. How do you know if someone had a loss of consciousness? I think many of us encounter situations that the kids, if they've had a obvious, complete, severe loss of consciousness, we're good at that. But the minor to the moderate, do you have any tricks on how to assess that, or things that we could be looking for or asking?
Well, first I'd say, is anyone who's would like to answer back on that question before I say anything? I don't know. Okay, I guess I have to say something, right? Well, it's hard to just look at the patient and say, oh, you're this or that. And I think that probably I would probably be very careful about what to say without doing more things to look at the child. Because I think that's something that would probably need to be a case that's built up from various observations.
Well, I know when the kids come to the emergency room, because that's where we're getting at, right? Is how to get a good history, what happened and who you're asking. If the kids are awake by the time that I see them, a witness said, in fact, she got struck by the ball. I asked the kid, do you remember being struck by the ball? And did you see stars? And did you black out? Or, where do you remember, what do you remember right before being struck by the ball? Were you in the park? Were you at a church? Where, can the kid provide some details? Gives you some information on a loss of consciousness, but at the scene, you can ask those same questions. Did you get struck? And did you see stars? Did you black out? Because if they can tell you that they did not get struck and they fell for some other reason, it's going to guide your thought process, I would think.
Okay. Should we go to the next scenario? I'll tell you the answers. There's only one answer because there's only one kid, but we'll try that. Why don't you read this one, Judy?
I can't, Dr. Frim. It's not on my screen.
Really? Ah.
Yep. And BSD emails out, so I don't have a copy. So I can't help you in that way.
Oh, this is bad, huh? Okay. I guess we start. This is the B version. Same kid, same mom, same walk in the park, and Judy, the child, runs to play with her friends, and then several minutes later, Judy's mother is startled. She hears a bump and a scream and runs to see that Judy is intermittently crying or screaming. Another mother calls 911 while Judy's mother tries to calm her daughter, though her daughter seems to be getting a bit sleepy, though easy to arouse and talk to. You and a friend are walking by. You see the group with the child on the ground and come to help. The child, Judy, is now intermittently difficult to arouse. So she's gone from a bit sleepy, though easy to arouse and talk to getting a little bit less difficult to arouse. Who has any ideas on that? Remember, she had a big, large ball.
Go ahead and drop your answers in the chat, or feel free to unmute yourself and share aloud. So the first answer we have is, if there is a lucid interval of a few minutes followed by LOC, it may suggest intracranial bleeding. And then the next answer says, cease fine precautions and open the airway.
Just two people.
The next answer says, call 911.
Indeed, yeah. The other mother was already calling. So that's good.
So the fact that you can't arouse this makes it more urgent, and you don't want to move this child, and, you know, wait for the 911 to respond. You don't have any, not that you could have done anything, even if you had some equipment. You don't move this child, but it is becoming more urgent now that we are not able, she's not arousable.
Yeah, all true. Something you taught me, right? Like
I have never taught you. It's always been the other way around. You have taught me.
So this is sort of in that the first one is a little bit hard to decipher. This one, even though it's sort of much worse as what may be happening, it's a lot easier to figure out, because the three people who were looking in that direction, I think all thought that this was something that was something that was going to eventually be rushing to a hospital someplace, because the up, down, up is hard to miss if the child is really slowly getting sleepier and less easier to talk to.
We've got one question, Dr. Frem. So it says, how long should you wait on the ambulance before you panic and see if there is a drill nearby? Just kidding, a little.
That's actually a really good question. A lot of people, you know, the sense of time is, you know, it might have only been 1 minute, but it feels like it's 10. You know, that's actually a really good question. I guess my answer, Dr. Frem, and then I'll let you answer. Yes, too true. It's an emergency. But what if you put this kid in the back of your car and they truly become absolutely unresponsive? I know you're on the way, but you don't have any tools or equipment to be able to, you know, resuscitate this child. I don't know. Knowing that the 911 was on their way, I guess you would know that community if you were walking in that park. You could at least start, if you had to, start CPR in the park on the paramedics. I don't know. That's a hard question, and a very popular question, actually, because we've had a fair amount of people drive their loved ones in, and by the time they arrive, they're much sicker than they had been.
Yeah, that's certainly a relatively common wait, and then all of a sudden it's rush, rush, rush. I think that there was, well, anyway, we live in Chicago. I mean, the environs of Chicago. And so, yeah, unfortunately, there's a lot of ability to get somebody from one place in the city to a hospital, since we seem to be very ripe with hospitals. But yeah, that's it. So this is to be very good at assessing the ups and downs of a child. I wrote this as a 7-year-old, but the same thing could be said about a 12-year-old or a 3 or 4-year-old, though the 3 or 4-year-old might be a little bit harder to assess.
And what do you think about one of the comments, Dr. Frim, was C-spine precautions? I think that goes back to, assessing what happened. If we thought the kid was having a seizure, then maybe we don't need C-spine precautions. Although I think you can always err on the side of consideration of C-spine precautions.
Yeah, I guess we were jumping a little bit because we're slow. But yes, all the rest of those things are important. The child is lying down. We would want the child to stay lying down. They want the child to not be moving their neck. And so all those other things that I've left out are still necessary. If there's a towel, right, we'll wrap it around the neck to make sure that the head doesn't move. If the head is going a little bit up and down, then you need to immobilize it. All these things that are keeping the child from getting anything more if they've already been injured.
And I would say from my experience, if this particular child was, say, not somnolent, but rather combative or confused, warrants the same level of concern and maybe escalating out of a level of care than you're able to provide in the middle of the park. Combative children actually make me very nervous compared to somnolent children, and not because somnolent means they're quiet and I'm not worried about them, but combative, it's just as concerning. And I think sometimes we forget that kids want to fight back because they're kids and they want to preserve themselves, but combative is not a behavior that we find in a lot of children, unless they've been injured or something like that, at least in this scenario.
Well, okay, maybe we should move on to the third one. This was the short one of the whole thing. Okay, this is going to be Judy's last walk. A delightful 7-year-old child, right, is taking a walk on the rather large park with the rather large ball, and her mother is walking with her. They reach the park. They get to they get where the mom reads the book and the kid plays. Okay. Several minutes later, Judy's mother is startled by hearing a bump and a scream and runs to see that Judy is intermittently crying or screaming. Her friends say that she ran into a tree. She also seems to be unable to speak well. One of the other mothers calls 911. I think that the mothers have that now. And Judy's mother tries to calm her, though the daughter seems to be getting very somnolent. Specifically, Judy, that's the child, her speech is now difficult to understand and rather halting. You're walking by, you see the group, and you go to see what's going on. Judy is now intermittently difficult to arouse. Okay,
Don't move the child and be ready to provide CPR.
I'm sorry, who is that?
Jaideep Singh.
Oh, yeah. Yeah, she's, I agree. She's probably going to be pretty sick when she ends up in her hospital place.
But in some ways, Dr. From this, compared to the first scenario that we were discussing, where there's a lot of unknowns, this one, you know, may have answered some of the questions that we had on the first one. If she ran right into a tree, she may have facial bruising or some skin, you know, integrity disruption, that she's bleeding from somewhere. She's clearly sicker, a little bit easier to decide, yep, in fact, we need 911. And as a provider, I can recognize that right off the bat. And we need to watch then for the basics of ABC. Although I will say all the considerations that we had in the first scenario, did she have a seizure and then run into the tree? That's possible. Did she trip on the ball? Did the ball hit her and then she ran into the tree? It would still be really important to ask those same questions. Did anybody see what happened? What details happened? Was she moving her arms and legs? You know, I usually say it's moving her arms and legs funny. I don't say seizure because it makes people, I think it makes people very nervous to say seizure, but if they say seizure, then I'll go with the word seizure. But again, gathering that information is so helpful to us as the receiving providers, or even someone in the audience going along on the trip off to the hospital. This one is a little bit easier, but some of the principles remain.
Yeah, certainly true. There's a little bit of being ominous about exactly what's happening to her. And so, in a sense, though the first scenario is the hardest one to kind of figure out what's going on, but as you say, I think Dr. Singh would have said that this was probably the patient that is in the most trouble, and seems to be going down relatively quickly. So that's the that was the third scenario.
So as a follow-up to that, since we have quite a few primary providers, one of the popular questions, if this girl had hit a tree, and let's just say she had no skull fracture, but she had a contact epidural, she's sleepy, she comes to our midst, we may have to do some surgery, evacuate the epidural. If it is a direct impact epidural, a lot of those children do well, and we're able to transition them back into your care. If you ever have any questions when a kid has had an injury and gets transitioned back into your care, by all means, from our team, just reach out to our team and ask. But epidurals, by and large, in pediatric patients, have a pretty good recovery. That doesn't mean they don't need some rehab services. We may need to help coordination with primary care providers to make sure they get their therapies and continue in rehab mode for some time. But they should be able to do quite well, straightforward for the epidural. Other traumatic brain injuries, it's a little bit different. Wouldn't you say, Dr. Frim?
Yeah, it's definitely a situation where you look at the child who looks very bad and has a dent in one of their parietal areas that can be a pretty deep dent, and the child is not breathing that well, all those things are true. But those turn out to be the patients that are the easiest, in a sense, to, if you get to them quickly enough, to take away the pressure from the broken bone, and then remove the bone, so that the brain then will, over the course of just like 10 or 20 minutes, will probably go back to almost the usual shape that it should be. And those are the children who wake up the next morning and they're talking. And I think it all has to do with how much blood flow was being compressed, and how long the whole thing continued. The subdurals, in contrast, are very difficult to take care of in that way.
And I know, Dr. Freeman, quite a few pediatric providers, or at least I suspect, they might get a call from a parent that, let's just say their kid the day before had run into a tree and were, they came home, reported, I ran into a tree and I have this facial injury, but I otherwise feel okay. What if the next morning the kid doesn't feel so great, complains of a headache? What would you recommend then? Because I bet that's a popular call to, general pediatrics, the next day phenomenon.
Yeah. Yeah, but that's true. And it's always a little bit ominous if the child is worse the next morning or complaining more the next morning. That's something that is good for a call to the pediatrician. Talk about it for a little while, because as much as there's a lot of children that I see through the pediatricians, it's best to be very, very cautious in these situations. Yeah.
Yeah, I would agree. I think, probably everyone on this call no longer believes in it's just a concussion. Sometimes a bonk to the head is, can be more ominous, particularly if they're complaining the next morning. Yep, I agree with you there. Any questions from the audience or personal experiences on that exact same thing, the late phone call, then how did you handle it?
Yeah, what are the indications for imaging when you get a call like this on next day? You go directly for the plain X-ray, or you get the CAT scan? What do you do?
I'm sorry, I couldn't understand that.
The question was, when you get a call like this, as Judy mentioned, what kind of imaging do you do? What do we have to do imaging on all the patients, or what are the indications of imaging on cases like this, like CAT scan or just simple plain X-ray?
I don't know, when I was practicing, I would usually advocate for a head image, so like a CT scan. That would give a good sort of quick view of what's going on as far as the bony part of the skull. If there's a dent, then everything needs to be evaluated, because once there's a dent, there's a lot of possibility in there being both a possibility of early injury that ends up becoming possibly a big late bleed, or it can start a cycle of swelling. So all those things are important, and so it's very important once you have the patient in your hands. You need to make sure that we, I mean, the neurosurgeons, know exactly what's going on inside the cranial vault.
So with that, so that's a popular question about should we just get x-rays? So x-rays will tell us it can tell us the presence of a fracture, but it doesn't give us a lot of characteristic of the fracture, nor does it give us any information of what potentially is happening beneath the surface, is how Dr. Frim has always taught me to think. Even linear fractures in smaller-ish children, they ran into a tree or they fell or something, may have a small subdural underneath. And that gives the surgeons that much more information. And we can't get that on a plain x-ray. Usually a CAT scan would give us that more information. And then to decide whether a kid needs surgical intervention also depends on how depressed the fracture may be. If it's a depressed, contact fracture here, if it's the bone fragments, it's broken into multiple pieces and really indented, the surgeons need more information to decide surgical repair. Although we can see that on x-ray, it just doesn't give us all the information. Does that help?
Yeah, I think that the use of the CT scan is probably what is being most used upfront for patients when they have deformed skull bones.
So I'm going to twist this scenario just a hot second. Let's just say the kid ran into a tree. There's no obvious mark that there's a fracture, but they call the next day and they have a headache, and maybe they the mom just feels like the kid is not themselves. They're kind of blurred, a little bit checked out, and they're acting concussive. One of the things that we can do when the kids get to us, we have we call it a quick brain MRI. So it saves the kids radiation from CT. If we feel really strongly that there's, fractures, we might still want to get a CT. But if this child is acting as if they're concussed, we can get rapid MRIs. So if you start hearing the rumor that we're getting quick MRIs instead of quick CTs, that is true. It's very short, limited sequences, and it saves the kids the radiation of the CT, but does give us information of what's happening intracranially as to whether they have something more involved that needs surgical intervention than concussion that may need a lot more medical support.
Yeah.
So Judy, if this mom called you late in the evening, and let's say this scenario didn't progress to where the kid was getting somnolent, but history of hitting a tree, fell down, then was arousable, and she wants, and it's late evening, the kid gets a bath and is going to sleep. Would you tell the parents to keep an eye on the arousal level or no, or just let the kid sleep through the night?
So I personally would tell the mom I would ask the mom, because the mom knows the child the best. Are you concerned? And if the mom says yes, then I say bring the child in. And if the mom says, well, I'm kind of concerned, but not really, I would say, then why don't you in a little while wake that child up? Maybe, 2 hours from now, just wake them up, make sure that they're responding to you. They know your name, they know where you are, they remember what you had for dinner, things like that. And if the kid can't do those things, or the mom's level of uneasiness goes up, then bring them in. I try to put a lot on the moms, because I think it's really hard to fit everybody into the box of if this, then that. Some of these kids have underlying conditions that the mom knows better that might make them more susceptible concussion type symptoms. For example, a kid who has ADD might act a little bit different than another kid who has a very chill, laid back personality who never, ever, ever, ever complains. I put it back on the moms. And I always tell every mom, if they call me personally in my personal life, or if they call me, if I'm on call, if you're worried enough that you called me, you're already worried quite a bit. And so if your worry goes up, bring them in, get them checked out. It never hurts to get them checked out, as opposed to nobody in the household sleeps because they're afraid something's going to happen. Does that make sense?
Okay, yep.
Yeah, nobody ever really had a bad problem because they went to the hospital and were told that everything was fine. The other
Yeah,
way.
and I think we all get those
Yeah.
calls, don't we? Like, doctor, nurse, hey, help me. Even if it's not your specialty. JD, you'd be surprised how many new moms call me about their newborns. And I think I don't really do newborns, but I'll try. I know some resources. I'll help if I can.
Sounds good.
So we've got about 5 minutes left in the session. So if you have any other questions, now is the time to ask. And I'm going to skip through the next scenarios. We'll get to those the next time. And then I'll put up our contact information on the screen here. So if you have any questions, please feel free to reach out to the MHFP either by email or by phone, and we would love to help you sort through all of these questions, whether it's a consultation you need on a patient or just generic questions and scenarios. Just let us know, and I'll also put up our website as well. So it looks like as I'm getting to that, there's one more question. It says, in this day and age, would it be okay to send in all hours urgent care?
Is it all right? You can't say that it's not all right, because it's already up to the amount of what should I say, the amount of anxiety, that the easiest thing is going to be to just take the child and do the workup. Otherwise, someone's going to be very nervous the whole night long, and that's not going to be very good. And you may end up finding something, so then that's very good too. So I think that's probably a sort of yes thing.
So Dr. Frame, do all the urgent cares have imaging facility? If not, what are we going to get by going to urgent care?
You know, we're a little bit spoiled because we have this big hospital, and we have a lot of CT scanners and MRI scanners. I think if it's a small hospital in sort of a faraway place, that's going to have to, you have to think a little more about that to decide what's going to be the best answer to the question of how do we work this child up. But I mean, it would all have to be a conversation back and forth between who's ever taking care of the child, presuming that that child's now in the little hospital, and to then have them do the CT scan and all the other stuff, and then say, oh, there's a subdural, and then all of a sudden everything is get the child to the big house right away.
I guess the other thing to think about, if the all hours urgent care at least has some resources, should this child decide to acutely decompensate, they may have more resources to get the kid to a higher level of care than, say, just a parent bringing their kid in the back of the car. But I agree with you that not all urgent care facilities are necessarily pediatric minded, certainly not toddler minded. But I guess you'd have to, as the primary provider, you would know your area and what urgent care is around you. There's a local emergency room near me that is not necessarily a pediatric emergency room, but they do have a couple of emergency physicians that are very pediatric minded. So I do tell people go to that local emergency room because I know they'll escalate very quickly and they are able to, at least get some basic workup and have someone assess whether they need to go to a higher level of care. Yeah, great questions. I love this.
All right, well, it is 12:59, so this concludes our session today, but you've got the email up on the screen, the phone number, the website, and I've also dropped them in the chat as well. So feel free to reach out to us with any questions. We'd love to help, and you'll also be receiving a follow-up email with me as well. So I will include the information about how to obtain the CME credit if you joined us a little bit later, and I'll also include our resources from the MHFP. So thank you for joining us, and I hope everybody has a great Friday afternoon. And thank you so much, Dr. Frim and Judy, for being with us today and just sharing your wealth of information. I think everybody learned a lot today.
Yeah, thanks for joining us.
Dr.
Always
Frim,
Thank
good-
you.
Always good to talk with all my old friends.
good to see you. Bye-bye.